Hello, I'm Michelle Lavander, Director of the USC Center for Health Journalism. Thanks for joining us and welcome to our Health Matters webinar covering coronavirus, the pandemic's unequal toll. COVID-19 has affected everyone, but not equally. Black, Native American, and Latino communities, for example, have suffered higher rates of infection and death. That's no surprise to those familiar with the deep inequities in the American healthcare system and in our society before the pandemic. Other circumstances contribute to the higher risk too. Low-income workers of color are more likely to be in frontline jobs with higher exposures, and some have a higher burden of disease and fewer options for safely sheltering in place. In this webinar, we'll seek a deeper understanding of these challenges and how to report on them with sensitivity. We'll explore how to be critical consumers of incomplete data, differences between rural and urban communities, and even how unequal access to testing affects the data picture. And we'll dive deep into strategies for telling stories that serve audiences, improve daily coverage, and help change the narrative by giving people information they need. Before we get started, let me introduce our distinguished featured speakers. Dr. Lisa Cooper is a Bloomberg Distinguished Professor at Johns Hopkins University School of Medicine and the Bloomberg School of Public Health. An internist, social epidemiologist, and health services researcher, Dr. Cooper directs the Johns Hopkins Urban Health Institute as well as Hopkins Center for Health Equity, where she and her team work on clinical trials and interventions to address racial and income disparities in health outcomes. Dr. Cooper's pioneering work documents disparities in the quality of relationships between physicians and patients from socially at-risk groups. Her honors included 2007 MacArthur Fellowship and membership in the National Academy of Medicine. She obtained her medical degree from the University of North Carolina at Chapel Hill. Jamie Fraser is an investigative data journalist for USA Today who focuses on health and its intersections with public policy, business, criminal justice, and inequality. Before joining USA Today, Jamie was an inaugural member of the ProPublica Local Reporting Network in Oregon, a state government reporter in Montana, and a local watchdog reporter in Texas. She was named a 2015 IRE Award finalist as part of the Houston Chronicle team that investigated the jail death of Sandra Bland. More recently, she taught an investigations class at the University of Montana, where she got her bachelor's degree in journalism. This webinar series is offered thanks to the National Institute of Healthcare Management Foundation, the Commonwealth Fund, and the California Endowment, and individual supporters like you. You can tweet about the webinar at the hashtag COVID disparities. A word about our format today. We'll be hearing from our panelists first, and then we'll turn it over to our audience for questions. Because we have many people participating in this webinar, we'll ask you to write your questions into the control panel of GoToWebinar. You can write us there if you're experiencing technical problems as well. And we will be archiving this webinar at centerforhealthjournalism.org. And now let's get started with Dr. Cooper.
So first of all, thank you for having me today. It's a pleasure to talk with you today about covering coronavirus and particularly the unequal toll on a number of populations in the US. So let's start out by talking about who the vulnerable populations and groups are with health disparities in the United States. And as you can see, there are many, many groups that are considered vulnerable in our country based on worse health outcomes. So people of color and people with low income are at the top of that list. And many of these groups overlap with one another because people in one group are overrepresented in another one. We also have women and children who can be vulnerable based on being low income. We have older adults, and we have a number of people with living with different chronic conditions, medical and mental health conditions. So you see the list here, and this list is probably going to look familiar when you think about all of the news that you've been hearing recently and you've been reporting on yourselves about the impact of the pandemic. But these are the groups that experience health disparities even when there's no pandemic. Some of the challenges that are magnified for these groups, we heard a little bit about this already. Whoops, I don't know what happened there, my slides went away. That are magnified for these groups include things like lack of access to basic resources such as food and water, shelter, and transportation. We've heard about, people being food insecure and basically having to go out looking for food at or trying to get, do shopping on a regular basis when everyone else is being asked to stay at home. People having to use public transportation. People living in multi-generational families living within crowded spaces. People not having access to running water to wash their hands, frankly. On the Indian reservations, we've heard of that. We've heard of this going on in urban areas and rural areas, but particularly among the groups that we are talking about, the racial and ethnic minorities and people living in poverty. You heard about the fact that many of these groups are overrepresented among essential workers, people, anything that's considered, anything where someone's being touched, people who are caregivers of disabled people or older people have had to work during this time when everyone's being asked to stay at home or to engage in social distancing. They've had to go out and clean health facilities. They've had to drive buses and subways, trains, and they've had to ride those public transportation options to use those to get back and forth. Many of these groups also lack access to health care services during a regular time, and as you can imagine, during this time, it's even harder to access healthcare services when a lot of the sort of elective care procedures and even just sort of routine visits are being postponed, and people are being asked not to come in for care. And so you have folks who are then now having to, first of all, not having access to a regular care, but then being asked to use, for example, use telemedicine when they may not have access to broadband internet to be able to do that. And then you have an understanding mistrust of institutions and of authorities because of historical factors, mistreatment in the broader society, discrimination, and also disparities in healthcare as well as in research. We've seen all kinds of things that have happened, exposure to different experimental research studies on African Americans, such as the Tuskegee syphilis experiment, such as the story of Mrs. Henrietta Lacks, a number of different situations, even current situations that make people in these communities sort of suspicious of authorities, and so less likely to necessarily follow through on advice without getting it from trusted sources. So my colleague Josh Sharfstein and I wrote an op-ed that was published in Politico in early April, where we outlined a game plan to help the most vulnerable in our society. And one of the things we said there was that it's not going to be enough for us to just use Zoom and and stay at home. That we actually are going to have to do other things if we want to make sure to protect the most vulnerable. And we also talked about why it was important that protecting the most vulnerable in our society is in the interest of all of us. So the 5 points that we recommended were, first, to track data on COVID-19 cases and to be very careful to collect accurate information about who is being impacted by this disease, not only who's being infected, but also who's getting treatment for it, who's dying from it, by factors such as race and ethnicity and geography, drilling down further into where these infections are clustered to get a better understanding of what could be contributing to this. We talked about the importance of leaders building trust and communicating frequently, and authentically, and clearly with communities of color. This is particularly a challenge when leaders are not engaged with community members who may be the trusted messengers in those communities. So we really talked about the importance of working closely with those communities and using messages that would resonate with them. We talked about the importance of enhancing access to testing and healthcare, being particularly mindful of the fact that that in vulnerable groups may not have cars and might not be able to use drive-through facilities, that they might need options that are closer to where they live, that we might need mobile units, for example, to provide testing. We may need to set up other systems other than sort of the traditional healthcare system so that people know where to call to have their questions answered about when and where to go for help during this time. We talked about the importance of also of protecting essential and low-wage workers. So we talked about how important it is to protect these workers, to be mindful of the fact that people are out there risking their lives, they're underpaid. We talked about the fact that that policymakers need to work closely with employers to assure that these groups are getting paid sick leave, for example, so they are not feeling like they have to work if they're sick, because we know that that not only is bad for them, but it increases the risk of spread of the infection to other workers and to their family members when they return home, as well as to people they encounter on the way to and from work. We talked about providing personal and protective equipment. We talked about offering hazard pay. And then we recommended, finally, but certainly not least important, is to provide social services to keep vulnerable groups safe. So we talked a lot about, you know, the needs that these groups have. And so what would those social services look like? You know, that would be a number of different factors. So we're going to drill down a little bit further into each of these 5 points. So the importance of tracking data on cases by race, ethnicity, and geography. The reason for doing this is that local and national leaders need to better understand who is at risk and what could be contributing to the risk as well as the spread of infection. So it's not a matter of just saying, well, we have, you know, African Americans are being disproportionately impacted. Well, why is that? It's not intrinsic to people being African American that they are being disproportionately impacted. Where are these infections clustering? Is it in certain neighborhoods where there are crowded housing conditions or where there's like not enough access to food? Are these neighborhoods where there's an overrepresentation of multi-generational families or essential workers? So a better understanding of who is being impacted will also help to guide decision-making around resources, like where should we set up testing? Where do we need more hospitals or more personal protective equipment for those hospitals that might be getting more of those cases? So we talked about the importance of data, but not data just not for the sake of you know, describing this problem, because again, for those of us who have worked in this field, this is not a new problem. We're not surprised by it, but we certainly want to have this information to guide our approaches and to track progress. Secondly, we've talked about questioning the data. So you can see from this slide that we're seeing these patterns of data where minorities are disproportionately impacted by COVID-19. This is death data, national death data, showing that African Americans in particularly have been hard hit. And so if this is national data showing that the death rate from COVID-19 per 100,000 people is much, much higher in African Americans than in whites, also than in Asians and Latinos. You know, there are specific states where we're looking at where the disparities are greater. So Arkansas, Connecticut, Illinois, Kansas, a lot of southern states, Michigan, also New Jersey, even in Oregon, where there's probably not even a high proportion of African Americans in that state. And then in particular cities and counties, we're seeing an overrepresentation of African Americans among the deaths. So, you know, looking at that data, but then also questioning it, how complete is the information? We know that the data on deaths is very robust. You know, people are required to record race and ethnicity on the death certificates and place of residence. But for data on cases, we're not seeing that level of completeness. You know, the data are being collected by labs across different states that may or may not record this information. So data that we're getting may not be complete for different states. Some states are actually not even reporting this. We have 40 out of 50 states that are reporting death data broken down by race and ethnicity, but fewer states reporting the number of cases broken down by race and ethnicity, and even fewer reporting the number of people being tested. So, but what we do know that is very clear is that African Americans are being disproportionately impacted. In New York City, we are seeing also Latinos were disproportionately impacted, but across the United States, it doesn't seem that Latinos are disproportionately impacted by dying from COVID-19, but maybe getting it at higher rates, in large part based on a lot of the factors we've talked about. And then again, very little data on American Indians and other ethnic groups, a lot of them being lumped into this sort of other category. And the quality of the data is, maybe unclear. Who's reporting this data? Is it self-reported? Is it someone who's a clerk at a hospital or a laboratory who's making a best guess of the person's death? The person's race or ethnicity. So questioning the source of the data, but tracking it nonetheless. Building and communicating trust with communities of color. We talked about the importance of that. I'm showing you some examples here of ways to do that. So for example, I've gone out and spoken with African American women using the Essence Communications web platform. The American Heart Association has very strong relationships with community leaders in African American and Latino communities. So using them as a place to get the information out. A lot of people watch CNN. We don't know to what extent the national networks are actually viewed as trustworthy, but we know people do watch them. We have had in Baltimore meetings with specific community advisory groups where we have opportunities for people to ask questions to medical and public health experts and get their questions answered. And same for across the state of Maryland, working with, again, trusted people who are either elected local leaders, or they could be other sorts of leaders of community-based organizations or faith communities. We also set up a website with a lot of resources listed for health professionals, for the community, for patients, and with frequently asked questions. And so when we talked about access to testing, I talked about this a little bit. I upstaged myself a bit about people who are uninsured or experiencing other barriers to care. And so, one of the things we've done is to do webinars for people who actually provide care to these populations to help them better understand what the best practices are and how to prepare to care for their populations during this time. We've also conducted webinars where we are exploring how the newer therapies that are available, to what extent they are going to be available to everyone, or if we're going to see certain groups of people such as minorities and those who are uninsured being left out of those trials. We wanted to really take a closer look at implicit bias and what role is that playing during this time. We know it's been an important issue in previous times. So in particular, we've heard stories, anecdotes in the media about minorities going in, seeking help and being told to go back home, and then actually ending up dying later or presenting very late in the course of the illness when they already have several complications and it's very hard for them to be helped. So, I just wanted to take a minute to talk to you about what we do know. The evidence shows is that from some of my work and that of others, that compared to whites, African Americans do, even when there's not a pandemic, experience less participatory visits with doctors, where doctors are more verbally dominant. They dominate the conversations of these patients, and patients are less involved and ask fewer questions. The visits tend to be characterized by more focus on biomedical issues and less on psychosocial issues. And we also know that when there's race concordance, or when doctors and patients share the same racial or ethnic background with patients, that those visits tend to be longer. Patients sound happier and more engaged, and they are more involved in decision making. We also know that implicit racial bias, which has been measured using the sort of famous now implicit association test, implicit racial bias occurs at similar rates among health professionals as it does in the general population. So there's about a 70% preference for white, 70% of Americans prefer whites over blacks in an implicit association race test, and the same is true for physicians. And we know that this implicit bias does lead to poor communication and experiences of care. So what role is bias playing, and how can we better unpack what is going on with that? It tends to be worse during times of stress. We talked about protecting essential and low-wage workers. And again, here, I'm not going to go into detail about this because we talked about it before, making sure that these workers have access to testing, supplies, and that there are policies that protect them with regard to sick leave. So who are the essential workers? You've heard a lot about this, but this is just data from the Economic Policy Institute showing that less than 1 in 5 Black workers and roughly 1 in 6 Black workers are actually able to work from home. So most African Americans and Latinos are not working from home, are more likely to have to go out and work during this time. And they tend to be the low-wage workers. And the low-wage workers are the ones who are kind of at risk right now. So it's no surprise that we're seeing these folks as, you know, at higher rates of COVID-19 infection. And then finally, you know, we talked about the providing of social services. And so if people cannot go out, cannot stay home, cannot engage in social distancing because of all the social factors they're facing, it's really important for us to bring those stories to light so that policymakers can address those issues and that we can build more empathy from the general public for support for these services, food delivery, housing in hotels or dormitories for people who don't have a safe place to go if they feel they might be exposed to COVID-19. Moratoriums on rent and on mortgages at this time and on utility shutoffs. Providing transportation for people who have to go back and forth to work so they don't have to put themselves at greater risk. Making sure people who are isolated and who cannot get out have some sort of connection to the outside world through social support. Making sure families with children have access to broadband internet or to computers or laptops so that they can continue their education. And then, so I just wanted to close with a couple of pieces. One of them is a piece that a colleague of mine, Dr. David Williams, and I just wrote in the Journal of the American Association, where we actually said that COVID-19 as an epidemic is not unlike health equity. Health inequity is really an epidemic that has been going on for many, many years. And so that we likened addressing health inequity as a way of developing a herd immunity, if you will, to the factors that contribute to health inequity. And so those factors, many of them are social and economic, and they do lead to these biological differences because, you know, these social and economic risk factors do contribute to worse health in general, which again predisposes people in these groups if they develop diabetes, heart disease, kidney disease, or asthma for having a more severe outcome from COVID-19. And so we also, David and I also have written about how to overcome some of these communication challenges. So one of them is that, you know, we really need to raise awareness about the fact that inequities in health exist. Believe it or not, a lot of Americans still don't believe that's true. There's still this belief that, you know, that there's been a lot of progress made towards economic equality in our country. Many people don't think of health in terms of social and economic factors. They still think of health largely as something that is determined by individual choice and behaviors. So we sort of have to change that narrative. We really need to try to create some trust in communities where people are sort of distrustful of authority and fact right now. People need to understand more about how even though poverty is a big part of why people have poor health, that race is still an independent factor. So, you know, we do know that even though there are race disparities in age and in life expectancy, at birth and at age 25, that we see these disparities across education and across income. So even though there's sort of less disparity in health among people who have less than a high school education, than there are in less racial disparities among people who have less than high school education. But among college graduates, we see a huge race disparity between African Americans and whites. So we know that economic factors play a big part, but we also need to make sure we help people realize that race actually and discrimination still matters quite a bit in health. We need to build political support. In order to build that support is like we really have to emphasize the fact that we've understood that one thing that doesn't work is actually trying to make the case that, you know, that basically trying to get people to feel that they must make things more fair, but really we do know that framing of the problem as something that is by focusing on our shared values, our values on interdependency on one another, our shared fate, on fairness between, not between individuals, but between places, is something that resonates well with people. So we know that those kinds of messages are important. We know that building public empathy can occur through sharing of stories of the challenges of people who are disadvantaged by actually appealing to helping people to connect emotionally with people. We know that that if we help people to focus on individual stories and identify some commonality with individuals, that we're more likely to build public empathy for this issue. We also need to focus on the communities that are disadvantaged and focus on the positive stories where we focus on what capacity exists in those communities and helping to build optimism within those communities and to share stories of strength and of innovation that can inspire people that this problem can be solved. And then finally, dismantling cultural racism is just basically encouraging people to put themselves in the shoes of others, using non-confrontational conversations, having people to read emotional essays and portraying the stories of individuals from disadvantaged groups in a way that that people can sort of relate to using mass media. So I'm going to stop there. I hope I didn't go too long.
Thank you so much. That was really wonderful. And I know we're going to have a lot of questions for you a little bit later in our webinar. We're going to turn now to Jamie Fraser, who's going to talk about the storytelling around these issues.
Hello, and I think you all should be seeing my screen right now. If not, let me know, Ryan.
We're good. But okay. I don't think, it may not be, I don't know if it's full screen, Jamie. I don't know if it looks fine though.
Okay. So I'll just start with some of the questions we're asking ourselves as reporters about the kinds of stories we're doing during the pandemic and the different types of responsibilities we have in our coverage. You know, there are 5 main categories, you know, daily information, things that we have to tell our community right away, explanatory, which obviously has a big role to play in this pandemic. You know, what are things we can help our readers understand about how the world works or what's happening in their world. Accountability and enterprise work that helps readers understand if their leaders are living up to their promises and holding them accountable for the decisions they make. Solutions journalism that highlights, you know, the best ways different communities can be taking action in the pandemic, what's worked in other places, what might work here. And then investigative work that really digs deep to compare the way things are against our standards for the way things should be, who is failing whom, who is profiting. These are all, you know, standard goals in our profession, right? So how do we change these questions to better get at stories about inequalities? And I'd like to emphasize that there's a difference between writing about vulnerable communities and serving vulnerable communities. Just because you have someone from an ethnic or socioeconomic minority in your story doesn't mean that the information in this story actually helps them be an active citizen in the community. So, you know, go beyond thinking about just getting those voices in your work, and really think about whether the stories you're writing day to day provide people in those communities with the information they need. You know, this pandemic plays into our roles as a public service, and it's a chance for us to build bridges where we know they've been lacking, and to be more creative and more innovative in the way we do our jobs. So going back to those same 5 categories, you know, think more deliberately about who needs the information you're gathering, and how do you make sure it gets to them? How do you make sure the information you're gathering gets to people who don't have internet access or don't have cell phones, or are not subscribers, particularly if you are, you know, touting your organization's work as public service during this time. You know, if you're sharing advice about how to stay safe in the pandemic, does it make sense, and is it accessible for everyone in your community? Is it in a language they can understand? You know, the example's been shared, you know, of washing hands. There was a doctor from the Indian Health Service facility on the Navajo Nation who, you know, said everyone's saying wash your hands, but 1/3 of Navajo homes don't have running water. So, you know, think about whether the advice and explanations you're giving to your readers make sense for everyone, or if your stories are only serving some of your community. You know, and when you're looking at accountability stories, or solution stories, or investigative stories, really be critical about identifying how decisions are impacting different pockets of your community, and, you know, think critically about that. So just as an example, early on in the pandemic, a lot of people are writing about hospitals and how hospitals could be overrun, and whether hospitals were ready for this pandemic. But 1 in 10 Americans don't get their health care at hospitals. They rely on charitable clinics or on federally funded health centers. And I wanted to know what their experiences were like. And so that led to this story, you know, calling health centers and clinics and finding that some of them had to close their doors, that they weren't receiving PPE or federal funding support the way a lot of hospitals were, and that they were struggling to reach patients who don't have phones, internet, or housing. And some of the closures were going to be permanent. They had to cancel fundraisers that provided all of their funding for the year. And so, you know, if everyone's zigging, sometimes you zag, right? Think about what part of this story is not being told. So I'll skip over some of this, and if you really want to dig into the nitty-gritty, you can find the PowerPoint when this is done. But this is advice that's been shared with me over the years that's been helpful when covering inequalities or working in underserved communities. You know, I'll point to the second one as particularly critical, which is do your research, but be humble. You know, if you're going to make a commitment to write about an underserved community, you know, learn what you can before going in, but be honest and open about what you don't know. Being able to admit that you're there to learn and that you want to get things right helps build trust and confidence, and helps people know that you're going to put in the work to get their story right, and not just, you know, take their quotes and run. You know, other things to keep in mind, you know, is to give your sources more information about how you do your job. You know, particularly when you're talking to folks in underserved communities that don't, you know, normally deal with the press or might already have a high level of distrust. It's really important for them to understand who you are, why you're there, what questions you're trying to answer, how you'll use the information they share, which is a lot more work than we typically do in our jobs or with public officials, right? But if you go that extra mile in explaining how you do your job, it can go a long way in making people comfortable sharing very personal information with you, frankly. I'd also encourage people to think about underserved communities as potential partners, not just sources. Make it a two-way conversation. If you make a connection with someone in the Latino community or the Native American community or in the disability advocacy organization, make sure you're inviting them to ask you questions. What questions you have for me about my job? What stories do you think we should be covering? What are stories we're missing? We'll make it a two-way conversation. And you could go a step further and form advisory panels or, set up, Facebook Live meetings where you have these community leaders with your reporters, speaking to the community, or panels. Think about ways you have shared goals and how you can use each other's resources and access to achieve those goals together. There are a lot of great groups doing innovative collaborative work out there, and if you Google collaborative journalism, you'll start to see them pop up. But I think a pandemic is a great opportunity to really evaluate the way we connect with underserved communities when we're doing our work. And I end every interview with, what questions do you have for me? Not the, do you have questions for me? Because if you present it as a yes or no, people tend to get cautious and just say no. But if it's, what questions do you have for me? You're making it clear that you assume they have questions and that you're open to answering them. A lot of times that's when people will explain what they're nervous about the interview or how it's going to be used, and it's your chance to build trust and build a long-time source. So as has been mentioned, think about public health advice that doesn't work for everyone, and here are a couple different stories that were built on that. Also think about going beyond your usual list of experts. Like Dr. Cooper said, find those people who are the community leaders, who are the trusted sources in their group, and have them help you navigate that world, but also include them in your stories or to understand what's happening in a particular community. Don't just focus on hospitals. Look at all the other different kinds of healthcare providers in your community that serve other groups, and ask them how the pandemic's affected their operations. Where are their patients going? We were talking before this webinar, and a lot of public health advice early on is, if you start to feel sick, call your doctor and they'll help you figure out if you need to go to the ER. But a lot of people don't have a regular doctor they can call, or they can't do a telehealth visit. So if you've always relied on the walk-in clinic for your health care, who do you turn to when you start to get respiratory symptoms? You don't necessarily have a doctor you can call that gives you advice on when to stay home versus when to go to the ER. So, the experience of the pandemic is going to be different as a result of that. When I'm looking for sources or to build community ties, I often go to community colleges and high schools. They tend to be at the heart of their communities and know the needs in their communities, and so you can build good connections there. If you have a chance, look at the stories you've done so far and really be thinking about who you're quoting. Are they all white? Are they all men? Are they all at hospitals but not at clinics? And be deliberate about reaching out to a broader range of perspectives when you're writing your stories. Another great resource are advisors and liaisons, people who serve on advisory committees or in state offices on issues of diversity. They often know, who are the go-to sources and can be good connectors for your work. Obviously, public health data is going to be huge as we cover this pandemic, and Dr. Cooper touched on some of the ways that that data could be better, particularly when it comes to tracking the disparate impact of coronavirus. The social vulnerability index by the census is a good way to compare, how vulnerable different communities are to economic and medical disasters, and understanding where those are in your state or even in your city. The Health Resources Services Administration is the federal agency that oversees federally funded health centers, and they collect a lot of data about medically underserved areas and gaps in access to care. So that's another good data source. I'm going to switch real quick to Census Reporter. If you've never used it, it is fabulous for just quickly getting a sense of place. It's a nonprofit group of journalists that makes it a lot easier to access census information. So you can type in a place at the top here, and I'm going to do Albany, Georgia, which has gotten a lot of coverage lately. So it's zoomed in on the city limits of Albany, Georgia. I'm more curious in the metro area, so I'm going to click that here. But then if you scroll down, you get all kinds of demographic information easily presented and with context. So for instance, you can see if you hover over the race and ethnicity here, that 54% of residents of the metro area are Black, which is 1.5 times as much as Georgia and double the rate in the US as a whole. All of these charts can be embedded. You can see the data beneath them. You can look at how people get to work. You can see the poverty level and how, again, these comparisons to the state and US rates are handy. So this is one of the go-to places I use if I'm just trying to quickly get oriented in a place that I haven't covered before or don't usually cover. Monitor the research that's coming out, and of course be cautious. Don't quote it without talking to someone who is involved in that research or someone that works in the same field and can understand the limits of it. Big Local and Open News both have data libraries and guides on different resources for covering the pandemic, including some that touch on disparities. And I'm a big fan of just build your own dang database. If you have a reporting question that the existing data cannot answer, open up a spreadsheet and start making your own. All spreadsheets are is organized information. So organize your thoughts and tell stories that no one else can because they're not going to have it. And be cautious about the data, like Dr. Cooper mentioned, right? Think about how it's collected and recorded. If we're not adequately testing in communities of color, the impact might be greater than we know, right? So if your state's not reporting the testing data by race, then how do you even know that the full scope is being collected, or that, and this is where it's really important, right? The idea that if it's bad data, that means public officials are making very important decisions with bad data. And that's the core accountability story that can be done, right? It's not just that, oh, this information's missing. It's that our public officials and our health leaders are making decisions with incomplete information. And so, highlighting that for your community can be an important service. So I have a ridiculously long list of story ideas, and I'm just going to skim over them because I want you to be able to ask questions of Dr. Cooper. But Indian country is important. Obviously, we're seeing much higher rates in some communities than elsewhere, and American Indians are served by an entirely separate healthcare system than the rest of us. Look at the finances of local hospitals and clinics, and how is that impacting access to care? Childhood vaccinations are down right now. How is that going to impact the long-term health of communities? Do accountability stories about who is getting money and rent assistance. Rationing started long before ventilators, right? Where do you go if you don't have a regular doctor or internet? Look at employer protections. Look at who your health officials are sending PSAs to and who they're not, who is getting advice and who is not. Look at essential workers, and what is the role that their employers play in protecting them, and who are these essential workers? Look at your state and county's pandemic and infectious disease plans. Did the state's communication strategies include reaching out to vulnerable communities, or were these vulnerable communities not included in the plan from the start? Hospitals and clinics that receive federal funding have to have emergency plans. Get a hold of those. Did they include an infectious disease outbreak? Did they include plans for how to best serve vulnerable communities? Group living, it's not just nursing homes. Look at jails, foster homes, work camps, halfway houses. There are a lot of stories that can be done there about, what are the challenges of social distancing when you have to share your living quarters with so many people. Again, this presentation is going to be in a link, so you can scroll through and steal these ideas, because I want to read your good stories. There's also a bunch of links here for reading on the topic of covering inequality or finding data related to coronavirus. But I'm going to go ahead and turn this over to the Q&A now, because that's what everyone really cares about, I'm sure.
Thank you so much to both of you. We already have some questions coming in, and I just want to invite everybody, if you have a question for one of our two speakers, to type it into the control panel question field, and we'll try to get to as many of them as we can. Just so you know, the Center for Health Journalism also has a new feature in our weekly columns called You Asked, We Answered. So we may pluck one of these that we don't have time for today for that too, and just know that's something you can reach out to us about in the future. We have a question from Linda Ju, who says, how can journalists identify how implicit bias is affecting care in their towns and cities and locales that they're reporting on?
So I'm assuming that question was directed at me, but I think both of us could answer that, Jamie. I would say definitely talk to people of color and people from vulnerable communities about their experiences when they're seeking health care. Who did they speak with? What did they ask? And how did people respond to them? What were they told? How did it impact them? How did they feel? But also, how did it impact their health, the rest of their life, the decisions they made? I think those are compelling stories. I think talk to the health professionals too about what it's like to work under these stressful conditions and make decisions under pressure, and have to kind of consider a whole variety of different things when deciding what to do about a particular patient, and how they connect with people who are like them and people who are different from them. So that's where I would start.
And you can also use data to help tell this story too, or at least help you ask questions, right? So if we see that, testing is more accessible in white communities, for instance, but the ER admissions for COVID-like symptoms are predominantly Black patients, that gives you a starting point to ask, why are we testing communities that aren't the same as those that end up seeking care? And why are so many people seeking care in the emergency setting instead of being admitted through their primary care doctor? So they're not necessarily going to tell you for certain that there's implicit bias happening, but it can help you ask questions and give officials something to respond to.
And we have a question from Alina, I'm not sure how to pronounce her last name, Basiu. A recent piece in the Albuquerque Journal talks about the effect among Native American groups as the third greatest cluster. And Alina says she's not sure about the data source for that, but wondered if Hopkins is working with the CDC or with Indian Health Services to support better data collection to characterize COVID impact in this population.
We certainly are. I mean, we know that there are certain states that are not reporting information broken down by race and ethnicity, and those are certainly the three of those states are states where there's a very high population of Native Americans, American Indians. So New Mexico, Utah, and South Dakota, have huge indigenous populations, and we're not getting the data broken down from those states. So we are working very closely with all of the states actually calling for that, getting that information. They may have it, and they may just not be reporting it at this time. I don't know if it's a workforce issue or some other technical problems, but we're definitely making them aware that it's important that we need this information based on what we know about health disparities among American Indians. I think there are a lot of stories that remain to be told about that group.
And I would, while data is helpful, don't let a lack of data or poor data prevent you from doing a story. And it's something you can highlight, right? That there is little information being shared publicly, or even leaders making decisions don't have adequate information. Again, make it part of your story rather than saying, there's not information I can use, so I'm not going to do the story. Talk to people on the ground about their experiences, report this using other methods.
And I just wanted to mention that Johns Hopkins has a very interesting tracker that we have in the resources connected with this webinar that shows the percentage of data, like the counties reporting in each state, so you can see how complete or incomplete it is. And it seems like that might be a valuable reference when you're making broad statements about a state, to also include how much reporting there is going on in that state.
And testing too. So one of my colleagues did a story about the counties that have reported no coronavirus cases yet. And a lot of those counties just have really limited testing. For instance, some counties in Montana were given 10 tests to last them for however long it took for the state to get more tests in. So if you only have 10 tests, you're going to save those for people that are obvious cases. And so just question the data. Just because you don't see cases showing up in the testing doesn't necessarily mean there aren't cases there.
And I think that's an important message for people living in those communities, because I think without knowing more about the limitations of the information, people living in those communities might actually feel that they're not at risk, because it's like, oh, well, we don't have COVID-19 in our county, when they actually need to know that it's not that they don't have it, it's just that people may not know about it. And so we don't want to give people a false sense of security about where they live either. So I think that type of story is important for policymakers, but also for everyday people.
We have a question from Linda Seltzer, who says, New York Governor Andrew Cuomo expressed surprise that the infection rates were lower for essential workers than for people at home and experiencing community spread. Is this the result of high density housing in New York City? What best practices are there for high density housing?
So, we've talked about a lot of different best practices. For example, my public health colleagues and I have been talking with people who own these multiple family dwelling buildings, buildings where there are individuals who, for example, have disabilities or are older, but they're living in a very large building where there are many other people in those buildings, and they have shared facilities to do laundry and a lot of common areas. They get a lot of deliveries for medications and meals. They have people who come in to offer services. And so we really have worked with a lot of local leaders to come up with policies around visitation, around elevator use, around use of common areas, lots of guidance like that for people living in those buildings. And so I think some of what we're seeing with the infection rates going up among people who say they're staying at home is that they are being exposed right where they live. Also, you know, people may not be following the instructions as carefully as we think they are. So I think we really need to get stories from people about when they're staying at home, like what does that look like for them? How often are they actually going out, you know, to try to buy food, or, you know, to do their laundry, for example. Maybe they're staying home as much as they can, but there are other limitations that they're working against. And so a better understanding of that problem will help us understand, you know, whether we can actually accomplish what we're getting at. And I think Jamie talked a lot about this too.
And it might also be a reflection of the fact that essential workers are starting to more adequately get protective equipment, right? And so it could be a success story that the rate among essential workers is lower because we managed to get them decent protective equipment. I know that that's up for debate and needs to be reported, but it's not just that if something unexpected happens, you have to look at both sides of why.
And Jamie, you have a question from Angela Woodall, who says, could you say a bit more about how you would use census data on Census Reporter in a COVID story? Are you using it to make connections between rates and socioeconomic characteristics?
So yes and no. So because I'm a national reporter, sometimes, you know, if I'm looking at, for instance, infection rates, and I see these 5 counties have the highest infection rates, I don't necessarily know those communities. So I use Census Reporter to get a sense for the communities, what might be some of the underlying factors that are playing into those high infection rates. But yeah, you can use census information to inform your reporting on the pandemic specifically. I use the Census's Social Vulnerability Index to point out that, you know, there are a number of communities in the US that already are vulnerable to medical and economic disasters, and they already have cases. So our response in communities that have less resiliency is going to be really critical, and those might be places to zero in on. But for me, the census is just a nice way to get oriented about a place that I don't live and I might not be as familiar. And it forces me to check my assumptions, right? Like the assumptions I would have about a town in Georgia, having never spent any time in Georgia, let alone lived there, you know, census gives me a chance to test my assumptions and make sure that when I do calls, I'm not, you know, asking questions that don't have grounding.
We have a kind of more of a commentary, but maybe the two of you would want to also address this, from Laura Williams, who says that she's been in practice for over 25 years now, and she's a data hound related to Native American Latino data and has been closely following COVID-19. She says she's been in touch with health departments in different counties in California, and that her understanding is that many Native Americans are being categorized in other and Hispanic categories, falsely elevating the Latino data, and that many Native Americans also have Hispanic origins, as do some African Americans, and that the categories that people are being put into are often being done by some intake person in a hospital, which can lead to maybe decisions on funding and resources and so on that are not 100% accurate and not necessarily confirmed with the patient. So I don't know if either of you had any thoughts on that comment, which we received by email, actually.
Yeah. So, well, I can say a few words. I'm pretty familiar with this issue based on being a physician myself, and really been calling for the importance of collecting this information for a long time. And I think what we've seen is that because it hasn't really been collected using best practices, and often in many cases, is that there's a misclassification of people. And that for the most part, we don't see as much misclassification of African Americans as we do of Latinos. A lot of Latinos are misclassified as being white or being a different race. There are some Black Latinos who are classified as being African American, but for the most part, we see a lot of misclassification among American Indians and among Latinos, that could lead to either over or underestimation of the impact of, you know, a particular health problem on that group. So I think another story is how important it is to train health system and public health personnel in how to obtain this information so that it's accurate and that it's actually self-reported, so that people can say who they are, as opposed to us guessing who we think they might be, or putting an unknown or putting them in another category. The other thing is that people may consider themselves to be from multiple groups. And so I think it's important for us to know how people self-identify. It's also interesting to know how the health system or the public health system identifies them, because what we've found is that basically a person's classification by the healthcare system is a stronger predictor of their treatment and their outcome than their own self-report of who they are. So I think both are important, but I think we need to know what it is we're talking about. Are we talking about people's real reality, or are we talking about some way that the health system has classified them?
And it can change at different points in the process too, right? When that report is made about a test that might be entered by someone in the hospital lab or at the state lab, but then if that person dies, the ethnicity listed on the death certificate is by the doctor who's signing the death certificate. So you can get the same person classified multiple ways. And, you know, if you're a local reporter, this is something you can, you know, do a check on. If you are monitoring deaths and you're talking to these families and you notice a discrepancy, you can talk about it. But it's hard to compensate for that without doing a ton of follow-up work. And sometimes we have to work with the information we have, even if it's bad. But as Dr. Cooper said, focus on trying to get better data quality to start.
We have a question from Garth Gibson, who says that he sees little reporting on the COVID response in the Asian community, which he sees as especially significant given President Trump's blaming of China in a number of ways, and some concerns about racism right now.
Yes, and I know we've certainly seen a lot more reports of Asian Americans experiencing discrimination out in the society, but not necessarily reports of them getting sicker or dying at higher rates. And I think, first of all, there's a lot of misclassification or underreporting of race and ethnicity for Asian people of Asian background. But so I think that's important. I think the other thing to keep in mind, though, is that Asian Americans overall as a group in the United States have higher levels of education and income than other groups, and that in and of itself may be a protective factor in this situation. However, it's still important for us to take a closer look at what the impact might be of the discrimination and the stigmatization that has come along with this particular problem.
I mean, I've seen local newspapers or city newspapers cover this topic where they have communities large communities of Asian Americans. You know, there's also been reporting on the disproportionate number of Filipino nurses or, you know, Asian migrant workers that are doctors or in other healthcare professions here on visas. So I think there is some reporting out there, but it's something that could use some more work too, as always.
I think unpacking the nuances and realizing that there are subgroups of people within these large ethnic groups. There are separate stories. There are people who are immigrants. There are people who are frontline workers. And so even what might be true for an overall group is not necessarily something that's the truth for an individual. So I think we have to also, that's a really important point for this reporting, is to not, for it to not result in further stigmatization and stereotyping of people, so that when we report information that, you know, is happening on a group level, we also have to remind people that there are certain risk factors that cluster based on, you know, like ethnicity and race. So, but that even within that, there are individual stories and individual circumstances that may or may not fit with the data that we see on an overall level. So sometimes people will use those anecdotal reports to sort of refute everything that we know that's going on a group level. And so we don't want to do that. But we also want to caution people against thinking, well, every single person of color you see is going to, have the same experience.
And that's part of why it's responsible to have diverse sourcing in your stories, and not just think, I'm going to write a story about the Black community or a story about the Asian community, but you incorporate those communities in your ongoing coverage, so that you get a more diverse and more nuanced picture of everyone who lives in your community, as it applies to the different topics you're reporting on. Yes, there is room for zeroing in on particular communities and their experience, but if you incorporate them into all of your coverage, it helps break down those stereotypes and allows you to get into more nuance than if you really shoehorn yourself into trying to come up with a narrative for just this one group of people that are diverse in their experiences and opinions.
Thank you. We have a question. We'll take two more questions here. We have one from Mike Stucca, who says, a big chunk of the latest outbreaks are in unusual population clusters, meatpacking houses, prisons, nursing homes. Are there any approaches you'd particularly recommend for covering these?
So yes, I mean, I think that there are clearly different circumstances that contribute to that increased risk. I mean, the general theme is that these people are in close proximity to other people and don't have as many options related to like spreading themselves, keeping themselves away. So I think that's the common theme. And there are clearly like a whole host of different reasons for the challenges. The challenges in a meat packing plant might be related more to like in employer policies, or like productivity concerns, things like that. Whereas in a nursing home, it might be more concerns related to staffing, and sort of the need to provide like certain kinds of like services to a large number of people. So I think you should look for the common themes across those situations. Same like, for example, in prisons, what are the common themes? What are the struggles that people in those situations have with regard to like not having power over their own space and living circumstances? And the people who are in decision-making roles, like what are the concerns and decisions that they're having to sort of grapple with? So I think look for the themes, and then what are sort of the unique contextual factors within each of those situations.
And you can start with, really basic questions. Why is the virus spreading more or impacting people more in this place, right? And then once you know why, what are solutions for that? Okay, so there are solutions. Why aren't those solutions being implemented, and who has the responsibility and power to make those decisions? And so you just follow it one step at a time until you go from an explanatory to an accountability story. You go from explaining there are outbreaks in nursing homes because you have vulnerable populations, or in meatpacking plants because there are tight quarters and you're not allowed to take breaks or wash your hands. And then you take it to the next level, the accountability pieces. So this is what experts say a solution is. Why aren't the owners implementing those solutions? Why aren't the county health departments implementing those solutions? My family lives in a small tourist town in Wyoming, and I was pleasantly surprised to see the public health officer there say that they've implemented random testing of people in businesses that interact with tourists, so that they can have baseline monitoring of whether there's new exposure in the community. And that was, good to see. So there are solutions, and the question is, what are the barriers to those solutions, and who is making the decisions? So that's kind of where you can twist it.
And for our final question, this is from Wyatt Massey, who says he has a question for Dr. Cooper. Are there examples you can point me toward of health departments responding to growing disparities in the data, such as reallocating resources? The local health department here has a growing disparity that has been apparent for weeks, and they have not changed their outreach efforts from the beginning of the pandemic.
Yeah. Well, I guess I'll use this as an opportunity to brag a little bit about Baltimore. Baltimore City Health Department, I know, is working very hard to put in place a contact tracing program that is going to heavily rely on community health workers, people who are from local communities that are being hard hit by this epidemic, to have those individuals involved in doing the contact tracing, because they know these are people who know the communities and who have the trust of many people in those communities, and that people will be less likely to give inaccurate information or to fail to respond, and that will be an extremely helpful way of containing further spread of the infection as we sort of move from this phase of complete lockdown to reopening.
Well, with that, we're going to conclude our webinar. I want to thank our two speakers and also our audience for all the good questions. Thank you so much. Shortly, you'll receive a survey that asks you questions both about this webinar and your ideas for what would be most useful for you for future ones. Please take a moment or two to reply. And then we'll hopefully see you all next week. Thank you so much.
Thank you.